Good afternoon. So we would like to welcome you to this MRI special interest group. For the one or two that are online, I would like to tell you that the reason why we are starting very late is that there's been a bus to a mountain close by, and that was delayed, and therefore quite a few people came in late. So just that you know that when you're online. Um, so my name is Mikkel Østergaard. I'm a rheumatologist in Copenhagen in Denmark, and we are four chairs of this group, which are Conahan from Leeds, Paul Bird from Sydney, we're both here, and then Charles Peterson from Declaration, how it actually is pronounced in Florida, um, and um, and then there is from the group as well also Olga Kubasova. So it was too cold for Charles to come probably. Yeah. So um, so what we are doing. Just a minute ago, so hit it there again. Yes. So what we're going to do today is first we have a round of short introductions from all of us. Then we have a first section which is around some of the work we've done in MRI and arthritis, and also evaluated according to PISA, not in very much detail, but at a more strategic level. And then we will talk about some of the things we've been doing since the last OMERAC, the knee and hip pelvis reference images for the whole body MRI system that we developed. And then we will go into a discussion of those three items together. And then in a part two, we will hear about a validation about a artificial intelligence algorithm for looking at the joint diffusion and synovitis in knees, and we'll come back to that. And then we will talk also about some future research priorities in the end of the session. So, but first, I think that it would be great if we could take a round, just mentioning who you are and where you come from, and if you have some other things to mention, or whatever you'd like to say, but not too long, so we can if we could start with you. Right, let's go back to you. Okay. With what? Okay, right, yes, right, okay. Right. Thank you very much. Right. So let's start, and then I'll minimize. Oh, by the way, Lorna, you are online also. Could you introduce yourself as well? Sorry, almost forgot you.
I'm Lorna Neal from Dundee in Scotland. and I have been at a number of OMERACT meetings. This has just proved a bit too far. I'm a patient partner with the PMR group and have been part of a number of other groups and have taken part in various Delphi surveys, etc. I'm particularly interested in imaging, having been a patient representative with the ACR Euler recommendations on imaging.
You don't seem to be muted, but we cannot hear you. So,
well, I'm finding the same with you. I can hear you speaking. I can't hear anyone else in the room.
Yeah, that's I apologize for that, but she heard that I wanted her to introduce herself, so that's at least a good thing. Can you try to say something again, Lorna?
Right. Can you hear me now?
That's much better.
That better?
Yes, it's fine.
Yeah, I'm hearing you less well. So it's right. You want me to introduce myself again?
Yes, please.
Right. Can you hear what I'm saying now?
Yes.
Right. I'm a patient partner. I have polymyalgia rheumatica and part of the PMR group. I've attended a number of OMERACT meetings, and I'm particularly interested in imaging, having been involved with the ACR Euler recommendations for imaging, and so decided that I would like to hear what was being said by the experts in this group.
So I don't know if any of you could try to get hold of people, seeing whether they can do anything. It's just then I continue. We heard something about it. We understood that you were a patient representative, and there is something with the sound from you and the Zoom. So we'll try to solve it. But from now we got to continue. But thank you for being there. Right, and I'll try to keep this to my mouth, and if I forget, please remind me, because that's probably needed to be heard. So we wanted to give a short update, as much as you can do in 10 minutes, of some of the stuff that we've been working with for the last 20 years regarding or seen from the perspective of the EUFISA, which has also been mentioned in several other sections or sessions during the meeting. And that is obviously the instrument selection algorithm that has been developed over the last years. The tools that has been developed by our group over the years are several, and they are not all there, but most of them are there. There's an RA scoring system, rheumatoid arthritis scoring system, which was developed back in 2002 and was also endorsed by OMERACT at that time point. Then there's been a PSA scoring system called SAMRIS. Then there's been a whole body MRI scoring system called WIPE, which looks at peripheral joints and entheses for inflammation. Then there's a Healing Society score, and there's a couple of hand OA scores, one of them called HOMERIS. The last two we won't talk more about, but what we'll talk about briefly is the three first. There's been a number of publications over the last years around the evolution of instrument selection under the OMERACT banner, and you've probably seen them. There's also the handbook around this, but much of what is in the handbook is also in particular Maxwell's paper. But anyway, there is a system for this instrument selection, and I can't go into detail with this, and that's beyond my the scope and also perhaps what I would be able to. But there is this, and here I need to sit down in order to be able to point. And there is these different things that should be accomplished: the truth, disability, and discrimination. That what is always has been, and what is suggested here that is that you look at the target domain. I'll come back to that in a minute, and then that it gets flags depending on if it fulfills the criteria or not. So there's truths, whether it's practical feasibility, whether the numeric scores make sense. That's a different type of truth. Again, then there is discrimination between groups of interest. And when you then look at all this, then you can go to an assessment and reach one of these three conclusions down here if that process is done. We are definitely not going to do that process here because that takes a lot of time, but I'm just going to go through some of the things related to this. Then there's also this SUMP, which is meant to look at the measurement properties of the different things, different outcomes. And what you see there is one from the handbook, which goes into this truth, which is the main match, which is the first thing I look at. Then feasibility, construct validity, intermethod reliability, test retest reliability, longitudinal construct validity, clinical trial discrimination, and threshold of meaning. That is organized by papers, and that is too time consuming. So what I would try to do is to take them more by each area, which I'll come back to. The first thing I'll look at is the RA MRI scoring system, which was published back in 2002, and then there was an atlas published subsequently, Annals, also in 2005. And what it does briefly is that it looks at different measures of inflammation, synovitis, tenosynovitis, and osteitis, and you assess that in different areas. And then there is structural damage like bone erosion and cartilage loss on joint space narrowing, which is also done. Then the OMERACT group with Mathieu Antonetta in front published a paper on how to work with imaging and look at these areas that you could look at from domain perspective, that if you're interested in the core domain, what is that? That's manifestations. And then what is the broader domain? That's inflammation. In this case, it could be then narrowed down to what we are really focusing on. In this case, for instance, synovitis, it would also be any other of the different things that are were mentioned before, and then what we actually measure, the synovitis components. And then if you look in the MRI, in this case, then you can see joint inflammation. We can detect synovitis, and what we actually measure is the different components here of synovitis, which will be in the next slide, here on the right in a minute, which is synovial thickening, increased blood flow, and permeability, which is a characteristic of inflammation. And then in different aspects, hypertrophy of the synovium, increased that signal when you give contrast agent and so forth. So this could be done for each of the different parameters, but that's more than what we can do here. Then there was this schema, as I mentioned before, and I've modified it a bit for the purpose, but the content of this table here is the same as what you have up here, just organized slightly differently. So, and here you then look into the different domain maps, which is what was previously called face validity and content validity, the construct validity and criterion validity, and all these things have been looked through for synovitis, which is the other thing, already many years ago. And it was also endorsed by OMERACT back in 2002. The same is true for bone marrow edema or osteitis and for bone erosion. So that is long done, you could say. Then tenosynovitis and joint space narrowing was added at a stage, and most of the things here we also have publications that demonstrate. So overall, if you take it briefly, then you have, you could say, green for most of these areas. Criterion validity is not a necessity anymore under construct validity according to the handbook. But there hasn't been an endorsement of the other things than synovitis, osteitis, and bone erosion back 20 years ago. And it's routinely used in clinical trials with MRI, this method. Then there is a psoriatic arthritis score, which is similar in many ways. That is actually wrong. I don't know why that comes again. Sorry, that was the one here. That is psoriatic arthritis. That's more or less the same parameters, but there's a few additional ones like bone proliferation and like periarticular inflammation, because that's seen in psoriatic arthritis in contrast to rheumatoid arthritis. And here we look into the modified SOMP, again, not with individual papers, but more what has been done. And what it turns out that most have been done for the inflammatory parameters, but not the criterion validity unless you consider ultrasound something that you can use as gold standard, and that's generally not the case. So that has not been done. But the other parameters have been shown for the inflammatory parameters, but the sensitivity to change and discrimination between has not been shown for bone erosion and joint space narrowing because there hasn't been done randomized controlled trials for that purpose. So therefore, there are some things here that we don't have data on. Perhaps it should be right, not Amber, but at least it's not there. It's not seen as the other things are. Then we've made a whole body MRI scoring system, which just illustrates here that it's quite elaborate for all the different regions of the periphery, both joints and entices, bone marrow edema and synovitis, and soft tissue inflammation in the different areas. And that has then been acquired some recommendations for how the images should be acquired in a previous paper. And here we only focus on inflammation. And there has been studies both looking at reliability and looking at sensitivity to change over time with this, and also discrimination between a placebo and a TNF therapy where it is sensitive to change and discriminative. So that has been shown, but there hasn't been any work on getting it endorsed, just looking at the different parameters. So if we go into this for the RA scoring system, then you could say that if you look at synovitis, osteitis, BME, which is bone marrow edema and erosion, it has already been endorsed, and there is also, it also has shown all the different components mentioned here. While for SAMRIS, if you look at the inflammatory parameters, then it does these different things between treatment, but there hasn't been an endorsement process. For the erosion component, as mentioned, it goes well with the scores and the construct validity and reliability, but there's no data on the discriminative between treatments. Right. And for White, only looking at inflammation, but in this case, both on in joints and in entices, and the fact that it's entices is not done very well with other methods because they are not covered in the other MRI systems. But there it actually also works well with data from in all the different topics that are looked at. Right. So this was a very short and quick, and what you can do in short time around what the data are without showing the data. Then I'll show some work quickly that we've been doing around the whole body MRI system. That was the one where we looked at both hips, pelvis, knees, feet, ankles, and shoulders and hands, and thereby it's very elaborate, and therefore it takes enormous amounts of time to actually do reference image set for all these different regions. And we created some knowledge about how reliable the individual components were for the last OMERACT, but we didn't have a reference image set, and that would be nice to have just as we have it for Brammer's. And in that scoring system, we look both at joints and entices, and we look separately at the soft tissues. In joints, that's synovitis, and in bone, and then it's osteitis, and in entices, we look for soft tissue inflammation around the entices, and then the inflammation, you can say, inside the bone, as you see here in this trochanter region, which is one of the things that you can't see with ultrasound because you can't put into your bone. So there is a scoring system, but there wasn't any atlas, and that's what we've been working on. And this is then done for all the different regions there are in that region. And this is just an example where you have the what we're looking at is osteitis in the greater trochanter, which is out here. So you're looking for bone marrow edema, so bright signal in this area, and there's nothing there. There's a bit here. There's more there, and there's even more there. And you're looking in the centimeter close to the insertion of the incisions. So that's an example. Another example is this, where you look into the soft tissue inflammation around the greater trochanter. Again, over here, normal here, a little bit of enhancement, more enhancement, and even more enhancement, very intensive enhancement here, so that you have a reference image to compare with when you're scoring images of the individual patient in that study. Similarly, we've done this for the knee, and you'll see all the different regions that are up here. And again, they are scored 0 to 3 in joints and incisions as before. And this is a drawing of one of the areas, the insertion of the patellar ligament onto the tibia, where again you look at bone marrow edema and you look at the soft tissue inflammation. And example here, that is the osteitis, so the bone marrow edema at this location here, where the tendon, the patellar tendon, inserts into the patella. You also look here and here and here, but for this specific scoring, it's this location where there's no bone marrow edema, a little bit of bone marrow edema, more here and even more there. So in this just illustrates all the different areas I haven't shown, but where there's also we think that will be helpful in the process of using this atlas, not the least in psoriatic arthritis, where the very diverse disease manifestations, both with entities and with joints, and in axial joints, actually would be a very relevant overall assessment of inflammation in that disease, and looking also at whether diseasal inflammation is decreased with drugs and so forth. But that's not the topic here. It's just developing of the material to do that. So the conclusion of this part of our session is that I've given a very, very brief status on the scoring systems in arthritis that has been developed, or at least some of them, with reference back to EFISA. And then I've shown you that we have created an atlas for the whole body MRI component, both for the pelvis region and for the knee region. Yes, and with that, we would like to go to a discussion session which Paul and Philip will share.
Thanks, everyone. It's a dizzying amount of stuff I know to go through in a very short time. But are there any comments about what's been done so far?
Hello, thank you so much. Wonderful work. So I just wanted to ask you about the enthesitis. So you divide into two components. One, when you have increased signal in the bone of the enthesis, and the other one is the soft tissue when you have inflammation of the adjacent soft tissue. So you give scores to these two components for the enthesitis. Is that right?
That's correct.
And another question is about I think when you mentioned the grading of 0 to 3 of bone marrow edema, do you have, I think, how is the grading, I think, scored in terms of extent of the signal abnormality or in terms of intensity?
That's sorry, that's a very relevant question, and I skipped that, but it is 0 to 3, and it's for the bone marrow edema, it's you're assessing the 1 centimeter, which is closest, which is within 1 centimeter from the insertion of the incisions, and there you need to be as bright that you consider it abnormally bright, and thereafter it's a question of the volume. So that means it's not a question of intensity, but the question of how much volume it takes up as soon as we are sure that it's abnormally bright. Is that understandable?
A similar scale for whole body MRI in pediatrics, and we thought that because sometimes we have signal intensity that clearly is not as bright, for example, as we see the signal intensity in the bladder or in the cerebrospinal fluid. And then when you have, I think, very bright as these locations, then you give an extra point, because we think that not only the extent, but also the intensity could represent more advanced stages of inflammation.
Right, and I think that makes good sense. In my mind, I think there's not one correct way of doing it. It could be a way of doing it, and it could also be not doing. We have decided not doing it because also we've traditionally not went in and said how bright should it be, and is it then only a small area, or is it more that should be bright? But I think the most important thing is that you make strict rules and follow them, and thereby I would expect that you would catch the relevant change, whatever. But I agree with you that your approach could be as reasonable as ours.
Just mentioning that if we don't take into consideration the intensity, only the extent, we get to a ceiling effect. So after some point, for example, if you have exactly the same extent over a period of time, but in the second time you have increase in brightness, so we give the same score if you don't.
That is an argument. On the other hand, you don't have the trouble in finding out how bright it should be to be bright. So there's perhaps a reliability thing that could be advantageous. And when we're doing whole body MRI as compared to a local region, then there's so many regions that we expected that that even though there's ceiling there, then we might get this sensitivity by having several areas.
Can I just say something, Paul, for the non-clinicians in the room? In the bundle of stuff you've seen thrown at you at the start, so we've developed tools for use in rheumatoid arthritis that measures activity and damage components for that disease. Similarly, for psoriatic arthritis, the whole body stuff is about spondyloarthritis, diseases that affect multiple parts of the body. And often, we don't capture them. So we're talking about a range of different diseases that this adult group covers as distinct from the JIA group, and clearly osteoarthritis, which is coming up. Sorry, bit of clarification.
Which that are due to inflammation. Great.
Quick question. So the score that you have validated was in RA patients 20 years ago, and nowadays the trials moving for pre-RA, so for the non-clinician patient with joint pain without swelling. Can we apply exactly the same scoring system to this new patient population?
The pre-RA population?
Yeah, for clinical trials specifically.
Yeah. Look, I think it's difficult because it's been designed for when we did most of the initial scoring systems. Philip will comment on this. There is potential for that, but we have to realise the limitations, because a lot of the data sets we did this on were in patients, many of them who had quite advanced disease. So we were seeing a lot of erosions, joint space narrowing, a lot of edema. So if we apply that to a pre-RA population, they're going to be different. So to be honest with you, we don't absolutely know how the metric will stack up. We'd have to do the trials, but it's feasible. We know it's reliable, so we then transplant it back to that population and try and see if those metrics stand up.
As you see with many good tools, this was designed as an outcome measure. It came out of OMERACT, but now it's being used in a predictive way. So you'll see in many of the Dutch cohorts who've got large pre-RA cohorts that they're applying Ramrus as a prediction, disease prediction tool, which of course requires different metrics. Also worries me a bit in such cohorts that you imagine that people don't have other joint disease, like this uncommon disease called osteoarthritis, which everybody's got. So if you just look at synovitis and osteitis, well, they're there in OA as well. So not surprising to me that their papers tend to show that these are not predictive of onset of disease on their own. And you'll know there's quite a lot of imaging algorithm work going on at present, trying to predict with either ultrasound or MR a good formula for all our positive ACPA patients who don't yet have developed. So happy to talk again to that, maybe when we're into our future research.
Just one comment. I think that as you also do in the ultrasound group, you say that you can say synovitis is probably synovitis. The definition of synovitis is probably fine. What we don't know is the sensitivity to change and all these things in different cohorts, like for instance, pre-RA, even though there actually has been studies doing that, but not on the Romarak end.
So I hope I heard you correctly. You mentioned that when you score the emphasis around the hip, you have to take into consideration abnormalities within 1 centimeter of the bone, right? Insertion. And with the ultrasound group, the enthesitis is really defined up to 2 millimeter, which is quite a difference. I personally think that it extends beyond, and it's really hard to determine. There are no histologic boundaries, but I wonder what were the thoughts around the definition of 1 millimeter?
Yeah, but I'm aware that it's very different from what you do in ultrasound or what is done in ultrasound. And I can't say what is most correct. The way we selected this was that our impression from having looked at many images is that the brightness you see is frequently extending quite a lot more than this 1 millimeter, which is mentioned with ultrasound. And that's the way we did it, more than from a pathological perspective, but more this, well, that's what we see when it's severe, and we think that's worse than when it's just a little bit of line close to the surface. So that's the reason why we think that is worse, and then we put that into consideration.
Just a very quick one. What are your thoughts about non-contrast MRI moving in the future to reduce risk of anaphylaxis and so that we can avoid excluding certain patients? I don't know, revalidate all the work that you've done, but with the non-contrast MRI.
Well, you could say that's reasonable. There is all the whole body MRI stuff is without contrast, at least. So, but it's correct that I would still think that if you want, it depends on the synovitis is better visualized, and particularly in those pre-RA patients you're looking at, where it's really difficult to see this slight amount of water that you see in the stir image, whether that is pathologic or not. Then it's much easier when you have that. So synovitis, it's better. So that should, in principle, if you do it without, be reevaluated, but not many of the other things like erosions and bone marrow edema, which are looked at without contrast. But you have a point, definitely. Yeah, we did that, and that was less. We agreed less, and it was less sensitive when we did that than 15 years ago.
But interesting to your point about where these scores get applied. Interestingly published as an MRI Ramrus SAFE score, it's called. So it's in the literature. What they've done is a non-contrast, and they've compared synovial thickening to post-GAD to see if there was some correlation, and there was. So people are looking at that. The hardest thing, I think, is tenosynovitis. That's the hardest thing to try and pick up without GAD, and that's difficult. But the damage things are all there.
So there is a trade-off between number of patients versus sensitivity of the technique, right? So if you're after a large cohort, then maybe MRI without contrast will give you a signal on synovitis, within reasonable time. If you have 20 patients and you need to prove your hypothesis quickly, and synovitis is what matters, or edema or something vascular, then you kind of go for very precise imaging, which is gadolinium based, and then you deploy very precise methodologies. And I think the more precise you want to be, that's the trade-off, but you can have a less number of patients.
The bigger studies if you use those potentially.
I would just like to make a comment from an industry perspective. Thank you for giving us this overview, because I'm relatively new to the MRI space. And as you can imagine, we're really trying to understand on the industry side how these other methodologies for imaging can be used, because X-ray, for example, is not necessarily sensitive enough to be able to see things in patients, for example, with psoriatic arthritis. And so we're very interested, at least I know my industry a sponsor, is very interested in really trying to understand how can MRI be used in studies effectively, and then how can that be used and presented to regulatory authorities so that they recognize the value add to it, so that we can bring it forward into labeling discussions. So that's why I'm here. And so thank you for this. This is
No, thank you. It's a great comment. I think always in studies where there's MRI zealots, we all want MRI in every study. And of course, the companies come straight back and say it's going to cost a lot, uncomfortable for patients. And I'll get a comment from patients in a minute. I'd like to hear from them. But yeah, and how does it add value for the FDA? That's where it ends up then.
But I think there's, you know, the field has advanced a little. So about a decade ago, we produced a white paper with ACR showing the predictive validity, all the metrics around this tool, which have only improved since that time. Also, at last year, there was was it the year before? The last few years go through very quickly. There was a combined meeting with FDA and Arthritis Foundation looking at outcomes for inflammatory arthritis trials. I don't know if you saw that meeting. It's worth having a look. So Nikolai Nikolov was there from DPART, and they remain open, I think, to this tool. My personal thoughts, and the others might jump in on this particular one. MR is an excellent tool for phase 2, for proof of concept, to tell you if it, you know, we could tell you in 50 patients per arm whether you've got a drug that's going to succeed in phase 3 or not. For a big phase 3, and this is why I think it hasn't been tested taking it to regulatory, is of course it's more faff doing it at a whole lot more sites. And normally often for those large phase 3, it's at least part of the reason FDA wants to see data is toxicity. So they still want to see numbers. So in a sense, if I've got a very large clinical trial, I probably don't need MR to show it's working. You can do signs and symptoms. The question is whether these days you can do a trial long enough against placebo to show X-ray change. And if you just wanted a damage score on MR, you wouldn't have to do gadolinium. So I think there's ways of changing the trial you do. Small proof of concept or phase 2, I'd use contrast enhanced MR. A larger phase 3 to make it more feasible, I probably might not, and do a bigger study where you get damage much better than X-rays, and you would be able to reduce your numbers. Bigger question, but it's an important issue that FDA is watching us and we are talking.
I know there'll be questions, and I want the patients to give us a perspective, and then we'll move on to Walter, who's ready in the starting blocks to go. Question, Mikkel, then you.
Definitely crucial that you consider what the purpose is of the trial. As Philip mentioned, that it can be different. So you say that you design your trial according to what it is you want to achieve. So that's what you also said. Yeah.
Alex, yep.
Yeah, this is a bit of an unadulterated advert for the SIG session that's happening at 5 o'clock. But just in case you don't know, the gold standard for disease monitoring in a rare pediatric rheumatologic condition, PMO, the more aggressive version is recurrent multifocal. That's why whole body MRI is pretty much the only way to monitor disease. There's a group that is working for OMRAC who desperately would like to conduct trials. It's going to have to be a small trial because it's a rare condition, and that's what we're working on.
Great, thanks. Yeah, I imagine with kids, for a whole body, they would be sedated, wouldn't they? You would, not always, they go in? Yeah. It's not a special thing. Okay, comment from the patients before we move on, and I'll put you on the spot.
I mean, I think any patient that's got inflammatory arthritis has had MRIs. And I think it's just the patient burden that you have to worry about, because I know I have trouble even being comfortable in bed without being on a board and going into a tube for 45 minutes. And added to that is if you're having an MRI in Toronto, you're probably having it at 2 o'clock in the morning.
we reduce that. And you could say that for sure that if you want that if you have in clinical practice, then ultrasound is used a lot more because it's easier in case you have the skills of ultrasonography. This is more for a clinical trial perspective where you get additional information around, for instance, structure, which is also important, at least in some trials. And that's the advantages. But for sure, it's more. And then you have the central leads that is possible, which is not possible. So there's some disadvantages and advantages of ultrasound compared to
Can I ask just a quick follow-up question on the patient inside MRI scanner? Do you feel like you're getting more information as a patient, you know, not the patient who's experienced patient, but somebody who just got array, and then you don't really know what your joints look like? Is that of value to the patient to know it or not?
They know about their RA. You know, an experienced patient will know enough. Like for me, I had one on my cervical spine because there was concern about inflammation there. And so I agreed to it because that's pretty important. If it had been my ankle or my knee or something, I probably wouldn't have agreed to it. So I didn't need to know that much. Yeah.
I have a radical idea. Maybe this is, I hope it's not a radical idea. And this is not me, the patient. This is me having not confessed to most of you that I'm also a pathologist. Oh dear. Have you talked to the veterinary orthopods yet? Because our patients don't talk. So our only metrics are pathology and this. Have you talked to how they're doing it yet? You should, because they've gotten very clever about it. And we have found ways to fund trials in dogs. Nobody wants to fund trials in dogs. We found ways to fund trials in dogs. So reach out to them and get some tips about how they are doing this, because if there's concern about funding trials in people in MRs, I mean, we whole body image dogs, man. Like, sheep are fun. Yes. Sure. Oh yeah, we do the same.
Just I think yes.
I would talk to them because we've also found ways of it. The topic that we're going to get into next, where you're talking about semi-quantitative versus deep learning and AI driven things. We're starting to do that in both MR and correlative pathology in our critters. So I think there's a lot of crosstalk where you'll find we're doing the same things, but we're not talking enough. And that's goofy because we're just big monkeys. So like, it's fine.
So just I think two questions, if you want to discuss, to respond to them at the end of the session is fine. One is about criterion validity that you show it in the measurement summary table. How do you consider, what do you consider criterion validity for whole body MRI? This is one question. The other question is some clarification about content validity. So for example, if you use just for the whole body MRI, so for the inflammatory component, you consider bone marrow edema as the inflammatory component. Is that right? Because it's non-enhanced, unenhanced. So we don't see synovitis. We may see some joint effusion, but without gadolinium. So the elements that you are able to see would be bone marrow edema and joint effusion. And for damage, it's very difficult to see erosions or anything. So it's basically for inflammatory component without having synovitis. Is that right?
Yes, you could say that the first question about criterion validity, that's a good question. The funny thing is that criterion validity is one of the things that have left in my mind. Now, you may consider it differently, but that's how I understood it, that criterion validity is no longer a obligatory thing in the handbook as I read it, because it said it's not always there. But I think it's important, and that will be challenging because it could be histology somewhere. Normally we consider histology as the answer, and then CT has sometimes been considered okay because it's very good for structure. So perhaps CT for the structural changes, but you're also right that in whole body MRI, where the resolution is fairly much poor, we are not saying that we can look at structural damage with whole body MRI at this stage. It will be later. And the other thing was content validity. Then you could say what we do is we look at bone marrow edema and we look at bright areas. And that is, you could say, effusion and synovitis to some extent. So it's a mixture. You could say because bright synovitis is also bright on the stir sequence, you could say, at least when it's inflamed. So it's a mixture of that. And that's what we could do with for content validity. And in whole body MRI, then you could say that the great content is that we have all the different joints, all the different entities, and thereby it reflects, you could say, inflammation and with a large comprehensive vessel that way, where you don't, even though you don't get the enhancement, which would be nice to have as well. So it's slightly, do you understand what I mean? That you could say a different type of comprehensiveness. Yeah. Right.
I just had a quick comment. I thought actually with RAMRIS that there have been some studies correlating MRI changes with histopathological evaluation.
Yes, definitely. And that was because Andrea was mentioning the WIPE system. And then you can argue that, of course, that it's not being compared in all the different regions where you take your MRIs and you expect that what it is in one joint, that's probably also true in other joints, which is probably, but not necessarily true.
Okay, we're going to go to Lorna. My name's Paul Bird. Hello there. If you want to comment, please go ahead and comment now, but no pressure, you don't have to.
Can you actually hear me? Can you hear me?
We can hear you, but it cuts in and out. So I think that's an easy.
I'm finding the same with you. Yep.
I think it's a network problem. So
you could chat, you could write it.
Write it into the chat box.
If what I was wanting to say just now from a patient's point of view is that the generality of what you see on the MRI on a personal point of had an amazing effect for me. I was getting investigated for PMR symptoms that had worsened and had a pelvic MRI. Can you hear me?
Really sorry, Lon, we can't pick up the audio. Could I get you?
Right.
Would it be okay if you type it?
I'll put it in. I'll put it in chat.
Thank you. That'd be great. That'd be
Put
great.
the comment in chat. Okay.
All right. So we'll pick that up as it comes through. We'll now pass over to Walter. I'll find it for you.
Okay, so I'm very fortunate to work with a radiology team that has special expertise in artificial intelligence. And I'm sort of a collaborator, not the prime investigator in this. The primary investigator is Jacob Yaremko, and his fellow, Benafshi Felfelion, has been doing a lot of the work with this. And Jacob, actually, as far as I know, is the only radiologist in North America with an endowed chair specifically devoted to artificial intelligence. But if anybody knows anyone in that capacity, do let me know. So what we thought would be important, and what my influence in this has been, to bring the methodology of the OMERACT method to the evaluation of an AI-generated scoring system. And, you know, I've been a devoted OMERACTee since 2004 and a strong believer in the method. And I think that we should evaluate an AI-generated scoring tool exactly the same, with the same principles of evaluation that we imply for other scoring tools, semi-quantitative tools. So here are the preliminary slides that you need to see, my disclosures. The radiologists have no disclosures. And this slide illustrates the purpose of the exercise. So this is the first step in assessing and quantifying synovitis effusion using an AI-generated algorithm. And what we wanted to do was to see to what degree the AI-generated scoring tool would compare with a manual assessment by expert readers using the traditional semi-quantitative assessments that Mikkel has already illustrated for whole body assessment. So we have two scoring methods. There's actually more, but we focused on two. First of all, there's the MOKS method, which is a 0 to 3 gradation, overall gradation of the degree of synovitis effusion in the knee joint. And then we have the system that we've developed, and actually much of the validation was done under the auspices of OMERACT at the same time that we were developing the hip inflammation MRI scoring system of HIMRIS. These are very granular methods for evaluating bone marrow lesions and synovitis effusion, scoring these lesions. So for example, for the MOKS, the scoring range 0 to 3. For HIMRIS, the scoring range is 0 to 100. So it's quite different. But of course, like any semi-quantitative method, it's subjective. It's only as good as the reader interpreting the method. So that's a problem. And it's not fully quantitative, even with a 0 to 100 scoring range. It's not fully quantitative. And we wanted to develop a method that was fully quantitative. So how did we do that? So this proceeds in a series of steps. And the first step is something that goes by various terminologies. So here we have labeling, but it basically means drawing. If you're interested in effusion, it means an expert at taking an outline of the region of synovitis effusion. So when you have fluid sensitive sequences, anything with water is going to be bright, and you can draw a boundary around the bright signal. So it's all, I also refer to as the hand of God, because this has to be an expert who's delineating this region in a precise way, the best possible way, right? And so then the computer takes all the information within that and at the boundary and within that region of interest, and it processes the data. And of course, the more of this labeling you do with the more cases that you generate, the more accurate the more the system learns. There's a computer, the computer system processes all this information and generates a mechanism, a way whereby it can take another set of images and basically delineate the area automatically and provide a number. So the system learns from the hand of God. That's basically, in a nutshell, what this is about. And there's various metrics that can be used to analyze the comparison between the hand of God and the system-generated region of interest, if you like. And that's something called this DICE formula. But there's also other ways of doing it, mean squared error, and other ways that I'm not familiar with. But there's various metrics that you can employ to compare the two. I should just put my glasses here. So then what did we, I'm not going to dwell on this slide. What was the objective of the exercise? So we're going to compare the tool that's generated versus these two scoring methodologies. And this is how the methods worked out. So first of all, the first step was to develop the algorithm. And this was based on scans from a very well-known database, the Osteoarthritis Initiative. And we've already have data from 53 subjects at 2 time points, baseline and 1-year follow-up, that has been scored by the developers of the HIMRIS method. It's also been scored for the MOKS. And yes, our scoring for the MOKS was quite good. quite a high degree of reliability, even though we're not developers of the MOOCs. And it was scored by experts, and the system then learned from our scores. So there was a drawing of the regions of interest, and the algorithms developed. And then we validated this in an external data set called OKINADA. And OKINADA is an investigator-initiated placebo-controlled trial of adalimumab in inflammatory osteoarthritis of the knee. And there are scans done at baseline in week 16 and week 52. And we focused only on the week baseline and week 16 scans. These are fluid-sensitive sequences, not contrast enhancement. So I think I can skip this, but one of the things that Benafshi has been doing is, you can well imagine that to get a really good algorithm, you really need to have a lot of these readings by the hand of God and lots of cases. The more cases you read, the more delineations you do, the better the algorithm. And she's figured out ways of reducing the number of cases that are required to generate a well-performing scoring tool. And the second thing is that she's developed a better way of delineating the boundaries, okay? Because you're really looking at a very the synovial effusion is a very complex structure, and there's very complex shapes. So the Kimmeris method does score synovitis effusion in all regions of the knee, but it can't possibly, in a semi-quantitative way, score the system in an absolutely quantitative way because of the tremendous variation in the shape of synovitis effusion in the knee. So that's what was done. And just to give you an idea what it looks like, this is the expert, the ground truth, the hand of God. And this is what the tool, how the tool performed, the algorithm performed. And you can see, first of all, appreciate several things, that these are relatively small structures, or can be. I mean, of course, it depends on the degree of effusion. And the second thing is the degree of matching. You can eyeball that and appreciate that it works pretty good. It looks good. So then we have this preliminary validation first with the MOOCs, and I think I've outlined that in detail, but we also look at the WOMAC. And so the WOMAC measures domains such as pain, function, quality, and stiffness. So we wanted to see also how the instruments compared in terms of their relationship to patient-relevant outcomes. So how did that pan out? So first of all, this is with the OAI data set. So this is cross-sectional data, so at a single time point. And this is longitudinal data, so it's the change data here, longitudinal and 1 year data. And you look at the correlations here, the closer to 1, the better the correlation. So here's Kimmeris and MOOCs, and you can see you get a decent correlation. Kimmeris and deep learning, heck of a good correlation, 0.76. So when we compare the deep learning algorithm with Kimmeris, the granular scoring method, we get a pretty good correlation. Then when we compare the deep learning with the MOOCs, you don't get quite the same correlation. That's kind of to be expected. It's not a granular scoring method, the MOOCs. When you look at longitudinal correlations, so here you're asking to what degree does the change in 1 year correlate with the change in the MOOCs and the Kimmeris. So we're now looking at correlations of change scores over a 1 year time frame. And you can see the correlation to the DL, the deep learning score, and the Kimmeris is, again, really pretty good. The MOOCs being a sort of a grading scheme, it's not going to detect change as well. So that's why the score is a lot lower. And here's what was really surprising for me now is when you look at the relationship between the deep learning score and patient-relevant outcomes. And what you see here is that for cross-sectional correlations, this is generally we don't see good correlations between imaging outcomes and patient relevant outcomes. But we actually do see pretty decent correlations between deep learning, and you can see a range of patient relevant outcomes, the change in KIMRIS and the change in patient relevant outcomes. This is actually pretty good across a range of MRI evaluations in different diseases and patient relevant outcomes. So I was actually quite surprised to see those results. No, I need to get to my last slide and it's not working. That might be because Mikkel's fiddling with it. Okay, thank you. So now this is just showing how the outline works for different sequences. You can see it doesn't matter which, because it's important to make sure the algorithm works for different types of MRI. And we've demonstrated that as well. The proton density, and this is my final slide. And this is now in the validation data set. This is in the OpenADA data set. And what we're looking at here again is correlation and change in over 4 months. 4 months isn't a lot of time for someone with OA of the knee, right? You see very little changes on imaging over 4 months. So you need to bear that in mind. So look at the correlations now between deep learning and KIMRIS, 0.86, which I think is really, really good. And you see the straight line there between the absolute quantification, the DL volume, and the KIMRIS score at baseline. But I think more importantly, because an imaging method to be used in clinical trials must have good reliability and must be responsive. And we're seeing that there's a good correlation between the change score for the KIMRIS and the deep learning volume change over 16 weeks. So we're comparing the deep learning score versus 2 methods that have undergone significant validation. And we're able to demonstrate that there is indeed some truth to what we're measuring with the deep learning algorithm. It's all about truth. These are some limitations. It depends on the data set. You have to keep reproducing the data sets. You need to look at other diseases. You need to have effective ways of delineating the margins. It's easier to do this with synovitis effusion than it would be with a bone marrow lesion, which has very diffuse heterogeneity attached to it. And of course, it's only as good as the hand of God. Right. So these are the conclusions, which I think are largely straightforward. So I'll try to answer the questions and say this is not my area of expertise.
Walter is
And
not
I've
God.
Predominantly
He works with the hand of God.
I predominantly focus on the OMERACT methodology rather than the technology.
Hi, I'm really excited with this work. Well done. I just want to ask, I guess, 2 main principles. So when you have you train the data sets, you train the machine for this data set, do you have do you need to have an equal demographic, for example, X number of patients in this age group, sex, ethnicity, early and established disease, just to make sure that your data set is generalizable when you develop it? And number 2 is when you've got the hand of God, what's the end you're talking about to get a fairly, sensible data set? So is it N200 or is it won't be N2, but could it 25? Can I get away with that?
Yeah.
Because I'd like to sort of apply this technology for other things like ultrasound, for example.
Yeah, so it's a very interesting question. Both questions very interesting. So the first question, sorry. Oh, sorry. Both questions very interesting. And the first question is an interesting one. I suspect that probably it shouldn't really matter, whether what the gender is or necessarily what the age is. You're just looking at what's on the image. Now, the second question, I think, is the more challenging one. And, you know, we have about 50 cases there. And what Jacob and Banafshi have been doing is, I think, exploring with the numbers. In other words, they've been using those metrics I've referred to, like the DICE equation, right? The DICE is a little bit like an ICC. The closer you get to 1, the better it is. So they've been looking at, okay, well, how many cases do you need until the DICE score kind of plateaus? Until, you know, it doesn't matter how many more cases you add, you're just not getting any further improvement in the DICE. And then you have to start looking at some other things like, is there a better way that you can delineate the region of interest, right? Because when you're looking at synovitis effusion, well, you've got other structures with different image intensities, and being able to easily delineate between those regions with different intensities could be challenging. So then you start to look at other things and other aspects of variability to try and improve that, you know, that reproducibility, if you like, between the gold standard and the algorithm generated region of interest. Yeah.
So I think, you know, what Walter is presenting is a particular methodology, which is called deep learning. And deep learning is one of the methods you can deploy using AI. There are many others. And one aspect of it, if you have a number of sets for training, you need to choose the right methodology. We use deep learning when we have a lot of data. For deep learning to work, you have to have thousands of masks depicting all sorts of information. Because it's called black box, you feed in, it comes out. But if you're thinking about ultrasound or anything like that, and you may have a specific question, you don't necessarily need to go for deep learning. You can go for something simpler with a smaller data sets and maybe come with a semi-automated approach, such as you have that mask, which is produced by the algorithm, and you could see they're different, right? The expert versus the algorithm, but you can amend, right? So in clinical trials, you generally deploy, at the end of the day, you want the volume of synovitis, let's say. Algorithm can go so far. So in this case, it goes 0.77, right? But the hand can go further. So you can have the same expert just amending it slightly and making it very accurate. So it's a support of a decision rather than a decision, right? It comes with its own limitations. But for specific questions on ultrasound, I would not go for deep learning. Your first question on the variability of data is very important because OAI data set is varied. But in ultrasound, you have different machines, you have operator variability, you have all sorts of stuff on top of the data. So that, if you deploy deep learning, has to be captured. And honestly, it's probably impossible because you have too many variations to produce reliable results. But there are other ways to do it though. You know, so it's...
We have an idea of where we want to go in the future, but what we want to do is see where you think we should go. Where should we engage? Diseases we should be looking at over here. Techniques we should be using.
Right. So Lorna, just she was trying to say something which we couldn't hear before, and she's written this. You can read it, but I'm reading it up. My experience was that a pelvic MRI was being used to investigate my worsening of polymyalgia rheumatica hip symptoms. It showed up not just severe bursitis as expected, but also osteoarthritis, which has worsened to bone on both hips. They are both now replaced very successfully. I'm very grateful to the imaging range of MRI. By the way, it also revealed an ovarian cyst, also now dealt with. So thank you very much for that. Thank you very much for that.
Yeah, I think Walter will make a comment, but I think it's why one of our radiologists calls MRI the truth machine. Apologies for Amrak. But it's the truth machine because you put people in and you get more often than you bargain for.
Yeah, I think this is very germane that as we all get older, when we scan a region of interest with pain, it's very common to see more than one abnormality. And then it can be quite difficult for a clinician to attribute. And you try and sort of incorporate aspects of history, physical exam, and with what you see in imaging to understand what the source of pain is. But this is getting to a diagnostic issue. And what we're really trying to accomplish here is being able to evaluate important domains. We're very focused on the domain issue, particularly inflammation and structural damage. And in what way can we best evaluate these domains to demonstrate, their responsiveness, reliability, discrimination? What way can we do that to make the tools useful in clinical trials and in clinical research?
Yeah, this is very, very exciting, and I'm aware, though I don't remember who the researchers are. I'm a PRP. I'm not a radiologist. I'm not a rheumatologist. But this is also being done using AI to come up with good scores for evaluating whole body MRI in CRMO. The question I have, and I apologize, but I'm burning to know the answer to this question, is for the future, for these types of tools, does the protocol that's being used to do the scan, does that have to have some element of standardization? Because I think that's a big problem. And how do, I guess, follow-up question, how does rheumatology, is it a communication thing? How do we influence the radiologists to do what we want them to do?
Alex, thank you. I'm just going to, I'm just watching the time now because we're running short to discuss the future, but in short, this is the area faced by every single disease area and trial. There's what sequences you do in a clinical study, and there's what sequences you do in clinical practice. In clinical trials, there's a whole industry. Olga has a company that goes around and makes sure that people in a clinical trial do everything in exactly the same way at every MR. And we also have to look at different machines to see if they capture things differently. In clinical practice, you get guidelines from different groups, not OMERACT. So for example, imaging the sacroiliac joints in spondyloarthropathies is a difficult thing. There's lots of abnormalities you can see. So there are now recommendations from various august bodies saying, here's the 3 types of sequences your radiologist should be doing. Make sure they're at this angle, make sure you do this, and make sure that the lesion you think is abnormal is seen on 3 or 4 slices or whatever. So it's an industry, but there's trials and there's clinical practice, and we should think about them as separate.
I think I completely agree with everything that's been said. Having said that, I think there's merit to pursuing approaches and validation exercises that ensure the development of a tool that is agnostic of the type of sequences. I've just been involved in a very large North American exercise where we had to get quality imaging of the pelvis and sacroiliac joints. And it's exceptionally difficult even in tertiary care clinical trial centers. And I think maybe we kind of have to acknowledge that's the world. We may not be able to change the world. And maybe what we ought to do is, as we did, as I showed you here, is look at validating tools that are going to work agnostic to the differences. But there has to be some happy medium, because in a clinical trial, you want to make sure that your baseline and follow-up scans are indeed as close as possible in quality as you can possibly make it. So it's sort of a bit of a happy medium, but it's a very important issue.
So I'm going to jump now into future directions, or else everybody will be asleep and the next session will be knocking on our door. So you've seen at the start a summary. We've got a history of doing semi-quantitative scores, eyeballed scores, and that's what everybody did. So we came out of, if you like, X-rays, where they had the Sharp score and then the Van der Heide Sharp score, which were semi-quantitative scores. Then we had this great tool called MR, and we developed semi-quantitative scores. Now the whole field of imaging is clearly moving into AI, but we've got to be a bit careful. As Olga alluded to, AI means a whole lot of different things. You know, unsupervised machine learning or deep neural networks. And so far that hasn't resulted in any clinical transfers, except in some eye retinal work where there's some, you can do pure maths on that. For everything else, currently where there's a lot of ML used, machine learning used, it's supervised. So in some way you train the set to measure something. And for that, as again, as alluded to, you probably need a data set that shows you the range of variation you're expecting in your population. And mostly that's going to be about 100 people or something in your data set for setting it up. So, and there are technologies out there, a lot of groups using these quantitative technologies. Their introduction into clinical trials is another bizzo. Some have been used in clinical trials, some have not. But back to our group. So we've evolved over time, as you would expect, but where do we go now? Because our audience, if we would just, there is a whole artificial intelligence, machine learning world that's very different from us. And they go to their own meetings and do challenges on, 10,000 images, show us what the difference is. So it's a different world. We'd have to think about evolving our group, which has been very clinically focused, as it were.
So I'm going to get Olga, for lay people, to summarize the key advantages of AI. Why would we do this?
Okay, so I think maybe advantages of AI, but generally quantitative imaging, right? Because not everything is AI, but quantitative imaging is very useful. So I think in my mind, the first thing is we're going into the era of new treatments, without participation rates. And what we have now may not suit the purpose of developing new drugs because it's costly. One patient costs a lot of money. You try to do CAR T therapy on one patient, lots of money. So we're going to end up with smaller trials with less patients. So we need more precise methodologies. And that's why it's so interesting for me how far patients can go for enriching of the data, right? If we can take 20 patients, but we have to put them in MRI scanners for 2 hours, but we know everything about them after that, and it's only 20 rather than 200. What is a trade-off, right? But quantitative imaging, precise imaging will lead to new biomarkers. And I think this team is fantastic. We have such an amazing case studies like Lamris came out of this group and in trials. We have others with quantitative pathology of the knee came out of university out in the trials, right? So we could be a place where people could validate or kind of have a path to take something completely new into the drug development. And I think that's very powerful for, having these chairs of the group who know what it looks like and people who like computer scientists who don't really know how it looks like. And then it's going across many diseases, right? From something we know well, RA, to something we don't know at all, scleroderma or lupus or anything, right? And I think it's a bridge, and it's a very powerful bridge. And I think AI quantitative imaging is just that bridge in a case. I think it may cost the same because you have more expensive therapy to develop and more expensive patient to take and more stuff to do. But at the end of the day, it's going to be faster because to recruit is another cost, right? So recruitment takes years, whereas this may take months, but more money goes into analysis, data, research. But, I don't know yet.
So we've mentioned AI. What else should we be thinking of? Is there other things that anybody, just while we've got this audience, Mark?
Thank you. There's a growing body of evidence that range of motion, particularly in the knee extension, is correlated with clinical outcomes, but also MRI outcomes. And MRI offers a fantastic opportunity to look at different anatomic structures that you couldn't see on X-ray or clinically, for sure. I'm just wondering if there's been any consideration of incorporating range of motion into the the imaging. And probably be challenging because, you know, the coil is uncomfortable to put someone in full knee extension, et cetera. But it'd be really neat to see, I think.
And again, for the lay audience, it's really hard to get range of motion within an MRI magnet because it's just not big enough. So some people have put in bike pedals to see some way. I've just self-funded a study of 100 people lying and standing using lying MR and standing MR. So we can look, because in osteoarthritis, which is a disease I care about, it's all about weight-bearing pain. And we've never actually looked at what changes when you stand up. It's sort of basic, but we've got to look at that stuff. So something about function relationships using some of this technology.
Because currently there's a lot of emphasis on prevention of RA, prevention of PSA, because that's where we're heading, but we don't have any good tool to measure. So the outcome measures that we have to choose now, for example, would be, has someone developed RA 1 year down the line? So some drugs, they quite good at sort of reducing some of the perhaps bone marrow edema and so forth. But we need, if we can apply this onto the pre-RA or pre-PSA or pre-anything disease, to focus on the prevention trial so that we can have a sensible, validated, OMERACT endorsed imaging tool. I think that would be excellent, because that's where I would put my money at.
Yeah, so I think that I know what Philip is talking about with respect to the industry, the AI industry, but what I have a question about is how much structure there is to that industry in terms of validating the AI tools that are being developed. And, you know, I think one of the things that we can do that is I think very valuable is to bring structure to how we evaluate these tools. I don't think we're going to make a lot of progress with the regulatory authorities if we don't have structure, methodological standardization and structure to our tools. And, you know, I think that's where OMERACT is preeminent in its rigor in the rigor of its methodology. And so I'm saying that I advocate for moving forward on this next phase of developing tools based on AI. That's just my thinking about it.
Are there other disease areas we should have thought about? Other disease areas I'm just throwing things out there to have people thinking. Are there? Yeah. Oh, you got a microphone.
Sorry to change the topic. It's a little bit different than I just wanted to see, maybe I'm unaware of previous publications, but I want to see consideration of the effect of sex on these measures. We do know that there are significant differences, including how patients start studies and the extent of inflammation and structural damage, possibly also progression. And I think it would be important to see how these tools function in men and women. And I think it could have influence on trials as well. It certainly has influence on potential diagnosis of patients. So
unofficially, I can tell you from 30,000 MRs we've analysed that bone shape and cartilage are definitely different between the sexes. About 0.5 millimetre difference.